Ellie is currently a PhD student at the University of Surrey under David's guidance, and she is investigating and modifying physiological processes associated with frailty and physical dysfunction in CLL. Ellie has a strong passion for working with the clinical population and increasing their quality of life through exercise. She is also a self-employed personal trainer and has played rugby at Premiership level with the Harlequins team in London. So highly recommended. And Ellie, please, the screen, so to speak, is yours.
Okay, so I'm going to first of all touch a little bit on frailty within CLL, as fatigue sort of feeds into that syndrome. And after that, I'll link that into the trial that we are running and sort of the results that are coming from that, and go into that into a little bit more detail. So firstly, what is fatigue? Well, there's actually no unified definition, but it can be defined as a medical syndrome with multiple different causes. That is characterized by a physiological decline that increases an individual's ability to recover from a stress. This then sort of starts to increase the risk of an individual's risk of adverse outcomes, so like hospitalization, longer recovery or longer stay in hospitals in response to, say, an infection or a fall. So we are, like Charles mentioned earlier, looking at that reduced ability to recover from a stressful event. And when we look into frailty within the CLL population, 60 to 70% of individuals are classified as pre-frail or frail. So quite a large proportion, whereby if you look at the community dwelling population, frailty only affects around 15 to 30%. And there's multiple different causes within CLL population to why there's this increase in frailty. The first one is that we have age-related factors. So I think everyone here knows that CLL predominantly affects the older population, and with that you get a lot of changes to the body, which can increase frailty risk. And as David mentioned earlier, you have the treatment, although they're great at targeting those CLL cells, they can damage healthy tissue as well, which can prevent or sort of affect systems within the body, which is driving the frailty. And then we also have the CLL cell itself, and again, that need for fat and for fuel that is stealing or potentially stealing that energy away from the muscles and the heart, and making them work inefficiently. And this can drive this increased frailty. What is often associated with frailty is physical function as well. So as someone becomes more frail, the likelihood is that their physical function decreases as well. And then this increase in frailty basically has a very significant implication for the management, prognosis, and quality of life of people with CLL. I just want to sort of talk about this graph as well in terms of looking at how frailty develops. So we tend to see that people who are resilient, who aren't frail, their ability to recover from stressful events is fine. After a cold, they may have a couple of days in bed, but they're back to normal after a couple of days. If you're pre-frail, that ability to recover is reduced. So after an infection, getting back to normal either takes longer, or you may never get back to normal. And then let me get my my pen up. You start to become dependent in your activities of daily living, and your risk of clinical events is increased. Then once you become frail, this recovery is a lot greater, and then this can lead to disability. And this development of frailty involves a decreased ability of your systems to return back to a normal state or a balanced state. How do we measure frailty or identify frailty at the moment? Well, currently, there is the physical frailty phenotype is one way of identifying frailty, and this looks at 5 different criteria. You've got low physical activity level, weakness that is often assessed using grip strength, unexplained weight loss, slow walking speed, and fatigue. So something that we've been talking about today. And this is quite easily measured within a clinical setting, which is why it is used to identify frailty. But these 5 characteristics are outward signs of what's happening underneath. So those systems that are no longer balanced, no longer working efficiently. If you are hitting 1 or 2 of those criteria, then you're classed as pre-frail. And if you're hitting 3 or more, that's when you're classed as frail. But like I mentioned, these are very observed outcomes. So it doesn't give us any idea of what's happening underneath and what those key drivers of frailty are. So just to put it into perspective, these are certain systems within your body that could be driving frailty. Or frailty, and in turn potentially fatigue, is that something that comes with being frail. So you do have your cardiovascular system, your immune system, your skeletal muscle system, so your muscles, and adipose tissue, and then your pulmonary system as well as certain systems that I've highlighted. And then in the blue or the purple bubbles here, you've got characteristics that may present in someone who is frail. So here we've got low VO2 peak, which is low fitness level. You've got a high or low BMI, so either malnourished or obese. You've got over with the skeletal musculoskeletal system, you've got sarcopenia, and then you've also got your immune system here, so increased inflammation. So within research, what we are starting to really get an understanding of is we can't just look at frailty from the surface level and those criteria that I mentioned previously. We've got to start understanding frailty at the systemic level and really see what is driving that frailty within different conditions, within different people. It will very much be different from person to person. But what can we do about frailty? So as an exercise physiologist, we can exercise to improve frailty risk. I think one key factor that it needs to be understood with frailty is that it is reversible, it's dynamic, so you can move in and out of a frail state. And one way of getting you out of that frail state is by engaging in an intervention, a lifestyle intervention, whether that be dietary, emotional, psychological support, but exercise is one of the main factors within research that has shown to reduce that risk of frailty or bring someone out of a frail state. So what we believe we can do is we believe we can bring this sort of accelerated aging process that we see within CLL. People with CLL, once they get diagnosed, they tend to decline quite quickly due to the factors that both David and I, potentially due to factors both David and I have spoken about already. But what we believe we can do with exercise is sort of offset those factors and allow you to sort of move back to a normal aging process. So as you can see here, we've got the frail down the bottom, you've got in red, then you've got pre-frail with amber, and robust state here in that green. Someone who is of normal aging, you'll see that you decrease your frail state will increase as you get older. due to normal aging processes. But if you get diagnosed with CLL, what we're seeing is this rate is accelerated. With exercise, we hope to bring you back as close as we can to that normal aging process so that you can live longer with a better quality of life. I gave you a very quick whistle-stop tour of sort of why we're doing what we're doing. And now I'm going to sort of talk about what is out there in terms of exercise within CLL. If you want more information about what I've just spoken about in terms of frailty aspects and the drivers of why exercise is important, the webinar that we did last year will give you all of that detail. So that is on YouTube for those that want a little bit more information about that. But in terms of exercise within CLL, like I said beforehand, we know that exercise works within other populations. There is just limited information out there at the moment within the CLL population. So one of the first studies that looked at CLL specifically was David's study that he completed over in America. And they looked at 12 weeks of high intensity interval training in active monitoring individuals. They had 10 people that went through the exercise and they had 10 controls. This exercise consisted of 3 times a week high intensity interval training, which is that period of high intensity followed by a period of active recovery, and also twice a week they did resistance training. What they found is they found an improvement in strength, which is really positive, and with that, improvements in quality of life. So all in all, great in terms of that sense. We did also see improvements in cardiovascular fitness, but both within those that have gone through exercise and the controls. Those that did the exercise intervention increased by about 5%. Those that are in the controls increased about 10%. So although we've seen an improvement, we can't tell necessarily whether that was down to the exercise intervention or the controls may went and got fitter by themselves because they were aware that they were in an exercise intervention. We don't know. So we can't really gauge anything from the cardiovascular fitness within that study. However, that was a pilot study and very few individuals, which is why we're doing the study that we're doing now. The next study that I'm going to briefly talk about is this Health for CLL study. It's a behavioural study. So what this group are doing, it's based over in, or what they've done over in Texas, is they did I think it was 16 weeks, I'll check that, but they did a physical activity and dietary counselling intervention with CLL patients, where they instructed participants to increase their physical activity level, increase their step count, and carry out resistance exercising. But they did this through either just talking to people, messaging people, just reminding them to do the physical activity. It wasn't set intensities and with people in a gym setting in the way that the pilot study beforehand did it. What they did find is that through just people naturally increasing their physical activity levels, there was improvement in physical function. So in those sort of tests of being able to get up and down from a chair, the grip strength, they found improvements there. And with that, they found improvements in fatigue-related quality of life. So just by increasing your physical activity level, by going out for a walk or being able to go to the gym and just getting moving, we saw an improvement in quality of life. Finally, one of the most recent studies that's come out is a study from Bath. They did 16 weeks of progressive exercise training in active monitoring CLL participants. And they did this over online. They did it supervised online. And they did 2 sessions a week supervised and 1 session a week walking around in their local environment by themselves. With this study, unfortunately, they didn't find any improvements in cardiovascular fitness. However, they did see an improvement in physical function through a sit-to-stand test, but both groups improved. So there may have been a learning effect there. But it starts to paint a picture of although we can improve quality of life through improving our physical activity levels, looks like we can improve strength pretty easily. There's something going on with inability to improve cardiovascular fitness, whether that be from the CLL itself, because these are predominantly active monitoring individuals, or whether that be from the programming that we are providing these participants. And that being said, another thing is that other studies that have looked at hematological malignancies have found that there's been an increase in around 16 to 25% using high intensity interval training. Yes, this was over 18 weeks. So in comparable to David's study of 12 weeks, they've got an extra 6 weeks on top. So that extra 6 weeks could have made the difference. But there's something to be mindful of, is CLL is obviously not fitting that mold that we are seeing within other malignancies. So what are we doing? Well, we've taken those studies and tried to really perfect our programming. So we are doing 12 weeks of exercise intervention training using high intensity interval training 3 times a week, but also continuous moderate intensity exercise training. So I don't think I mentioned this, but the Bath used moderate intensity interval training, moderate intensity training. They did lower levels rather than that high intensity vigorous training that David did in his pilot study. So we've combined the both. We've done 3 times a week of high intensity interval training, as well as continuous moderate intensity training thrown in there as well, to sort of target different metabolic systems and energy systems that exercise to promote a different exercise adaptations. And then we've also done the 2 times a week of resistance training, as we've seen really good positive improvements within David's study. What we've also done is starting to look at both active monitoring individuals as well as those people who have gone through treatment and now in remission, or who are currently undergoing treatment. So we're starting to look at CLL as a wider picture. Regarding our assessment, so before someone comes in for an exercise assessment, we before they come in to do the intervention, we require them to do a assessment or come in for an assessment day in Guildford, where we do a lot of baseline measurements. I like to sort of describe it to people as a body MOT. We look at resting ECG measurements, we look at resting blood pressure measurements, we look at someone's body composition, so how much muscle mass they have, how much fat mass they have, looking at their resting metabolic rate, so how many calories they burn at complete rest. We do the physical function tests that the previous studies have done, so we can compare our results to theirs. And we also do the frailty tests that I mentioned previously within those 5 criteria. We do what's called a cardiopulmonary exercise stress test. So this is a maximal exercise test where we strap people up to ECGs and a mask over their nose and mouth as well. And that's really beneficial, as it allows us to make sure that someone's safe to work at the exercise intensities that we require from them. But also we then get individualized markers. So we not only get their peak fitness marker that we can monitor before and after the intervention, what we also get is their peak heart rate, which we use to then individualize the training that we do to the individual, so that everyone has their own program to tailor towards their ability and capability and needs. What we also do that the other studies haven't done is we start to look at those systems that I mentioned. So rather than looking at the observational picture, we then start to look underneath at the systems. And we've got a couple of different devices that we use. We've got a PhysioFlow, which is another ECG, which allows us to have a deeper look at cardiovascular metrics. We take blood, we look at the immune function, we do ultrasound scans of muscle to look at the muscle quality, and we also have a device called a MOXIE, which looks at near-infrared spectroscopy, so the oxygen that is being delivered to the muscle. So all these things start to paint a picture of what's happening at the observational level, but then what's driving those observational markers through looking at the systems below it, and what are we changing, what can't we change, what does our intervention target individually, what differs from person to person. After the 12 weeks of intervention, either by coming into the lab with me or my team, or doing it at home using the watch that Charles mentioned earlier, so I can make sure that he's actually doing his sessions. We provide an app and equipment where needed. People come back in and do the assessments again, so we can get a before and after. And like I said, this allows us to start targeting those different systems that I mentioned before, or gain not necessarily targeting, but gaining a better understanding, so that then going forward, we can start tailoring our programs to target specific areas which that individual may be most dysfunctioned in. What do we do? Well, the results. This is really exciting for me to start talking about this. First time I've actually got enough people to actually see some trends going on. So we've got 26 people who have gone through the exercise intervention. So gone through the 12 weeks of high intensity interval training with moderate and resistance training as well. We have 7 people that have gone through control, so having gone through no exercise guidance. I think the first thing that I wanted to look at was that frailty score. So the score that people use to determine, or clinicians use to determine whether someone's frail or not, we also do within this study. And we've seen that as someone goes through the exercise, we see a nice decrease in that frailty score. So someone is becoming less frail during the exercise. Interestingly, people who have gone through the 12 weeks of control, so no exercise guidance at all, they're actually becoming worse. So their frail state is increasing. When we split it into the treatment groups, it tends to be driven by those that are treatment naive. So we've got a really good response from the treatment active monitoring individuals, but the active monitoring individuals on the control, they decreased quite dramatically. Their frailty score decreased quite dramatically. So the positive there is that we're managing to pull people out of that frail state or reduce their risk of frailty. Going a little bit deeper into those observational markers that I mentioned, one of those observational markers is the grip strength to monitor weakness. And we can see that we've got a nice, about a 6.5% increase in grip strength in those that have gone through the exercise. And the control, we did see a decrease in their grip strength. So something there is causing that accelerated physical dysfunction, or physical dysfunction that we're seeing. When we break it down, both treatment, active monitoring and treated are increasing pretty similarly, but we do get this dramatic decrease from treatment active monitoring. And fatigue. David's already mentioned this, but I thought I'd throw it in there as well because it is part of the criteria, and we are seeing a very nice increase in fatigue-related quality of life. And also both treatment naive and treated are also improving their fatigue levels. What does that look like in terms of the systems? Well, I could go on for days about talking about all the different systems and different tests that we're analysing, but I have just picked out 2. So the first one is fitness levels. So in our study, our HIT-CLL study, we have managed to increase or improve fitness levels by 11%, which is more than what we saw in any of the other studies that I mentioned previously. So in terms of refining and understanding the exercise that is best suited for those that are going through a CLL diagnosis, we're starting to understand that, which is really good. Interestingly though, those on the control, we decreased about 5%. And to put it into perspective, people tend to decrease by 1% every year. So we would expect to see a 5% decrease in 5 years. Within 3 months, we are seeing this 5% decrease. And so it'll be interesting to see how that number changes as we get more controls going through, whether that's consistent with the next 7 that we've got currently controls on the study, or whether that is going to sort of level out, and that was just within the 7 that we had, because I'm aware that that's quite a small number. In terms of VO2, in terms of when we separate them into treatment groups, the naive or the active monitoring, we're seeing a really good response, which is positive. But the treatment here, not so much, slightly less. Then when it comes to strength, we're seeing a nice big increase in our strength, our leg strength, and both treatment or active monitoring and treated also are increasing lovely as well. I very quickly threw this one, the slide on at the end, because we are starting to see a little bit of treatment, a little bit of effect within or differences within those that are on treatment naive and those that are treated. So it's starting to highlight the fact that we can't put everyone in one box. So we can't treat those that are on or program or treat those that are on treatment active monitoring the same as those that are going through treatment. Equally, we're starting to see some differences within the treatments itself. I won't keep going on about this too much anymore, but I do want to highlight this BTK inhibitor. I think one thing that we're seeing is that there's a reduction in response in this BTK inhibitor, which essentially is down to what David mentioned earlier regarding the treatment potentially affecting the muscles and the heart. That being said, although we're not seeing a great response that we are seeing, say, in the other different treatment groups, what we are being able to do is offset this massive decrease in fitness level. So the main takeaway that I want to sort of give to people is that we are seeing some really, really positive improvements from our study, and which is made me really happy. And we are starting to really understand what exercise works best for those who are going through a CLL diagnosis. And we are being able to start to pick out what works for what individuals and what different treatment pathways that they're going through. And we hope to sort of start really understanding those differences and honing in on different programs that we can provide people and hopefully give guidance out in the near future. Thank you.